everyone, my name is Caitlin Dugan, and I'm a data scientist at Cityblock Health. Healthcare has been top of mind for a lot of us recently, and many of us are interacting with the healthcare system far more than in the past. And every interaction, even a quick visit, generates a massive amount of clinical information. At each appointment, care providers are documenting new and existing conditions, evaluating treatment plans, and adding relevant patient information in the notes. While dates, diagnosis codes, and identifiers are captured in a structured format, the vast majority of information lives within unstructured data. And these are the types of data that my colleague, Eric Hilton, a senior data scientist on our team, and I are most interested in. In this discussion, we're excited to share our results and our challenges while working with clinical notes data, and we'll share our vision for how we want to use this information to uncover health and social insights for our patients. Now, I'd like to introduce Eric. Eric has spent much of his time studying the universe as an astronomer, and now he's swapped galactic neighborhoods for neighborhoods a little closer to home. Please welcome Dr. Eric Hilton as he describes our work at Cityblock.
Thanks, Kate, and I appreciate being introduced at a doctor at a healthcare summit, since not really that kind of doctor. But yeah, so before we get really into the details and the technical implementation of our model, I'd like to talk a little bit more about Cityblock Health and social determinants of health, and in particular, why Cityblock cares so much about social determinants of health. So pictured here is Cityblock co-founder Toyin Ajayi, who, if you haven't had a chance to hear her speak, you really should. She's an inspiring person who has a very inspiring story and tells it very well. But a lot of what we're going to go through here, is stuff that she's learned in the course of being a doctor, and some of the stuff that tools that she wishes she had. So, Cityblock is a community-centered healthcare company that focuses on delivering personalized medical, behavioral health, and social care to people, mostly in low-income neighborhoods. I just really want to emphasize that we're like a healthcare provider. We have primary care, behavioral health to people who have kind of historically been marginalized. And our business model is premised on the idea that providing primary care, mental health, social care proactively and preventively is a lot cheaper. An ounce of prevention is worth a pound of cure, so to speak. It's also better for our members and better for the community. So these are kind of these like knock-on effects of having healthier people, right? Healthier people, obviously it's a win for the individual people that are healthier, but also having healthier people is better for a stronger community. And it frees up a lot of resources in the healthcare space when you have people who are not chronically ill coming into the hospital and taking up time with doctors. So there are some additional benefits to this. And it's not necessarily like a super revolutionary idea to come up with preventative care. We're not the first people to do that. But one of the things that we really do is provide some tools to make that a lot better. And so I'll give you an example around diabetes. So diabetes is something that we understand how to manage medically. Like it's doctor can tell you how to manage your diabetes. And if it's managed well, then it can be okay to live with. But if it's not managed well, then it ends up being very expensive with hospital admissions, ER visits, and sometimes even, massive surgeries, right? So like there's a clear win if we can manage diabetes well. But the problem is that not everybody does manage their diabetes well. And you can imagine if somebody is, for example, working 2 jobs, it can be really difficult to get to their primary care physician between the hours of 9 and 5 on a weekday, which is where most traditional primary care physicians operate. If they don't have transportation, it can be really difficult to get there. If they don't have access to food and healthy foods, if they're food insecure or financially insecure, it can be really difficult to eat well to manage diabetes. And so even though we know how to manage diabetes, it doesn't necessarily mean that everybody's able to do that. And so if one of these people who has trouble managing their diabetes ends up in the hospital, we can maybe fix that acute problem in the hospital and then send them back home. But those structural problems that got them there to begin with are not solved, right? And that's the thing that Cityblock is really trying to do, is to provide the tools that insurers and traditional providers don't have so that we can really address some of those problems. And so we do that with an integrated clinical care model that's tech-enabled, and we try to meet members where they are. And that is both metaphorical and also like actually literal. We have folks that we will send them to your house. To see them, in lieu of maybe going to the emergency room. We have virtual care. We have clinics that operate often outside of typical business hours, and we try to really treat our members with dignity. Right, that's a big part of what we do. We have community health partners, and they're a big part of the toolkit that works to sort of provide this extra layer of social care that doesn't exist in the traditional system. And one of the things that is, I think, really important to emphasize is that, the cost of one emergency room visit, if we can prevent that, we can spend that same amount of money and give tens of hours of a community healthcare partner's time to address some of these social needs. So we work with the neediest patients, often those who are dual eligible for Medicare and Medicaid. Cityblock started in Brooklyn, has since expanded to several other states. But many of our members have housing insecurity issues, food insecurity issues, and some of these difficulties, right? Like as we said, like we're working with some of the neediest patients. There's a lot of substance abuse disorders and behavioral health issues as well. And so, we take them on. That's one of the things that Cityblock does is sort of work with this challenging group of people, and we need this extra tool set to address that. So the social determinants of health are specifically, to get a little more technical here, are non-clinical environmental factors that influence access to healthcare resources, the likelihood of developing chronic diseases, and the clinical outcomes, right? We know that social determinants of health are really important and they actually influence outcomes, but they're often really under addressed. Like they're not coded very well. They're not treated typically within the traditional healthcare system at all. And they're captured, if they're captured at all, usually within free text, unstructured data sources, such as clinical notes. And I just want to say that this is actually a really hard problem. So as we go through this, you'll see some of this, but social determinants of health are really complex, they're nuanced, and they can really even be very ambiguous. It's not entirely clear sometimes what somebody's housing status is or what it might mean, and it could change really quickly. And because they've been sort of neglected in the healthcare system for so long, we don't really have a great language for all of this stuff, and we don't capture it as well as we do some of the other more clinical stuff. So I'm going to turn it over to Kate next, who's going to talk a little bit about housing insecurity specifically.
Awesome. Thanks, Eric. Yeah, as Eric mentioned, there are many different SDOHs that can impact a patient's disease state. One of the most commonly present, highly represented, and really clinically impactful determinants is housing insecurity. So the amount of research into the relationship between housing insecurity and disease states has really been growing over the last few years. The amount of research, as well as media attention, there's numerous studies and correlations found between the lack of secure housing and the prevalence of diseases. And these are diseases like cardiovascular disease, lung disease, and an overall lower life expectancy. Not only do housing problems impact individuals and their quality of life, these diseases actually impact the larger population and the healthcare system as a whole. So as we mentioned, we see these statistics in journals and entries, but really, at least in the United States, we see a renewed urgency to really understand the ways that housing and healthcare are intertwined. So SDOH data is tricky. We've established that there's a clear link between housing insecurity and poor health outcomes, but it's actually really hard to quantify the relationship since there are significant challenges in retrieving complete and up-to-date data. While some databases do track the number of individuals sleeping in houses, they don't include individuals who are experiencing housing instability or inadequate housing or some other type of housing problem if they're not in the shelter system. They may be sleeping in a park or in the car, and these individuals are not captured in the databases. Claims and billing data are two commonly used sources of data for clinical information and diagnoses to be captured. And social determinants of health can actually be captured as ICD codes that begin with a Z, and these are known as Z codes. The problem is that Z codes are known to be underutilized by providers, so claims are not a good source of SDOH information at all. Finally, clinical notes have information about individuals' living situations, but the data is unstructured, and as a result, it's really hard to access it in a standardized and repeatable way. So based on the challenges listed, we know that identifying housing issues through traditional means is difficult. So our first approach to acquiring this information was to use John Snow Labs' named entity recognition model, or the NER model. And we use this to identify and flag the Z codes that are in clinical notes. So with this data, we hope to really understand the relationship between disease states and housing issues with the overarching goal of improving patient care. We wanted to learn which individuals are more impacted by social determinants so we can be proactive in providing care to them. And finally, we wanted to quantify and really understand at the population level what the impact of housing issues are on healthcare and health system utilization. So let's take a moment and look at a typical note. So notes contain all sorts of information about medical conditions, social determinants, lab tests, and values. Clearly, the information contained within the notes is large and really useful, but unfortunately, most of it is unstructured, and it's really hard to pinpoint anything at a glance. So you do see some conditions on the problem list. You can even maybe pick out COPD or heart disease within the note, but also tucked within there are references to homelessness. So to prevent providers and teams from having to read through every single note for just a few words, our plan was to use NER to flag these conditions with ICD codes. So in order to extract the data from the notes, we set up a model pipeline, and this included a number of annotators from John Snow Labs. Essentially, it read through the text, located target entities, and then was able to label those entities. The first JSL trained models that we used in the pipeline that I want to highlight are a sentence detector, a clinical word embedding model, a clinical entity detector, an ICD resolver, and also a clinical assertion status model. So these were all models that were used and trained on clinical data so that we could better distinguish between the nuances between medical notes and other forms of text because medical notes are so specific. The sentence detector was trained to understand the boundaries between the sentences, so we could split the note into multiple sentences and get a better understanding of each. We used the clinical sentence detector in JSL's library because we wanted to make sure we were collecting the right sort of clinical notes. The word embedding model that we used, this was the lookup annotator that allowed words with similar meanings to have a similar representation. So here, there's terms like chronic obstructive pulmonary disease and COPD, which really mean the same thing. So we wanted them to be recognized as the same condition. We had a clinical entity detector, and this labeled each part of the sentence as a problem, a test, or a treatment. Now, in our case, we were looking mostly at ICD codes, so we were primarily focused on problems, but having this ability is useful when using other sorts of data. We used an ICD resolver, so this mapped extracted medical entities to the ICD codes, which is really important to flag those codes. We used the augmented model, so it was tagging both synonyms and actual diagnoses codes that were listed. And finally, we used a clinical annotator, which was really important because we wanted to differentiate between someone who maybe has a condition currently versus someone who has had a past with that condition or the condition within the family. So to run our data through the models, we extracted and cleaned up our notes. We assembled the pipelines as we saw in the last slide, and we ran the data through the pipeline. Typically, we input the information directly into a data frame or a table, but here we're going to add some visualizations to look at some examples of notes data. So in this example, it's a sentence that was tagged by the clinical NER model, and it was tagged as expected. So, right, we see problems like anxiety and homelessness and severe abdominal pain just marked clearly. In fact, on the broader data set, the entity recognition model did detect a number of ICD codes that were related to SDOH conditions, including incarceration, food insecurity, and other financial problems. And we'll see an example of that. Another important part of the model that we mentioned is the assertion status. So we really wanted to flag whether a person had a condition or if it was a historical or if it was related to some other family member. And in this note, you see that the identified medical conditions and social determinants were tagged and the correct assertion status was assigned. So while this example produced expected results, other notes were flagged incorrectly, and we found mislabeled conditions as well as conditions that were not tagged with the ICD code. And this is an example. So unlike the earlier example, here we see without permanent residence, and this actually was a case of housing issue being missed, really, because if a person, does not have permanent housing, that's something that really should be flagged. Interestingly, we do see that Z651 was flagged, which ties to another social determinant of health, which is incarceration, which again might be helpful for future studies, but it doesn't help us when we're trying to look at housing issues right now. All right, so I'll be transparent here. Initially, we thought that NER models would be the quick solution to figuring out housing problems and all of our dreams would be made true. Unfortunately, not quite the whole story. As mentioned in the earlier example, the note data didn't always provide clear indications of housing for individuals. So sometimes the information would be hidden or within other phrases, making it difficult for NER models to draw any conclusions. So we can review a few examples here. So the first one is a patient was staying in a few different locations, sometimes sleeping in their car. So here homelessness is never mentioned at all, but we can infer it because the patient is not stably housed and needs money for rent. Another example we see is a patient was sleeping rough between July and September. So sleeping rough is sometimes used to describe a situation where they're sleeping in the environment because they don't have a permanent enclosed housing option. So this includes sleeping in a park, sleeping in a car, just where other more stable options are not available. Another example that we found was a patient mentioned that they broke their leg while roughhousing. So conversely, roughhousing has nothing to do with living arrangements, but it does mention rough and housing. So instead of references to rough play, instead this references rough play, usually by children with their friends. So another instance where it was incorrectly flagged by the NER model. Finally, we see a patient stated that they had been staying at Abby's house for the last month. So, for those of you who are unfamiliar with the shelter system in Massachusetts, Abby's House is an organization that provides temporary shelter for women with or without children. So, unless someone is actually aware of the various temporary shelters available in Massachusetts, this might be misinterpreted as someone just, staying with their friend. So, as we see from these examples, it becomes increasingly clear that there are challenges in interpreting note data through NER models alone. So right here, we'll pause to recap. In the beginning of this undertaking, we created an NER model pipeline built specifically to identify mentions of housing issues. As it turns out, this approach presented a number of challenges. One is that patient changes state over time. Sometimes they're unhoused, maybe they move to a housed status. Multiple descriptions of housing problems come up. So we saw sleeping rough versus rough housing. And then depending on the location where the note was written, there might be specific text to that location referencing or not referencing homelessness. A few takeaways from this approach overall or just that NER models are affecting and catching a lot of instances of housing insecurity, but really when homeless or housing problem or specific words are visible and mentioned, but the models performed less well in cases where there was more ambiguity around the terms or the words that were used to talk about housing insecurity. Additionally, the SDOHs are clinically undercoded in claims data. So for housing insecurity as well as other conditions, this can impact the models during training just because there's fewer references in the data overall. So after this initial dive, we decided that, really this isn't an NER problem at all. Individual words and phrases are useful when trying to identify disease states, but they're much less effective when we're looking at, complex housing issues. So this being the case, a combined approach was needed, and we needed to use a different model to understand housing insecurity within our population. So Eric will describe the second method that we used, and this is classification.
Yeah, that's right. So after the NER approach really didn't work for this particular problem, we decided to go with Classifier Approach, basically a binary classifier that uses sentence level embeddings. And there's several advantages to this. One of which is that binary classification is generally just a more straightforward problem than NER. So we figured it would be a little more effective at reaching our goal. And by doing sentence level embeddings, we figured we'd be able to capture a broader range of wording. So as Kate mentioned before and showed some examples of, the way that we describe various housing issues can come in a lot of different forms, and sentence level embeddings would be a much better way to capture that, right? The whole note has too much information, and there's a whole lot of parameter space captured in a large note that's about many things, but at the sentence level, it's probably the right grain at which to capture this sort of complex space. The other thing that's really nice about this classifier approach is that we can use it for additional models, right? So we started with housing, but and we're just getting started here, but we're planning on moving on to other social determinants of health, and we expect to use the same method here. So in a classifier, again, we're going to need a sentence detector, and we used BERT embeddings for the sentence layer. So this is the model that we used. Again, this was sort of for prototyping. We had the light model pipeline here. And I just want to point out real quick, a quick tip for anybody following at home. The parse embeddings equals true. If you are using embeddings in a light classifier, make sure you pass that in. That one threw us for a loop for a little bit there. Okay, so yeah, also just want to mention real quick, there's 768 dimensional embeddings here. So, pretty powerful work here, a lot to be done. But with the classification model, the other thing that we really need to do is label the data, right? That's one thing that's important and necessary for this. And we could give a whole talk just about annotation and how you label the data. The first thing is that it took us many iterations of sort of like figuring out how we wanted to label this and what our rules were for the annotation. And first off, we have to say it was rather naive of us to think that we could do this without subject matter expertise. So, one of the reasons we picked housing to begin with was because we thought that Kate and I should be able to sort of read a note and understand what it meant without being especially experts. And it turns out to just be wrong. Like, it's so nuanced that we really did have to talk to several people within Cityblock to get their help. And we identified we wanted to bring in a lot of the sentences from notes that had had stuff to do with housing. So the little box on the right there, those are some of the keywords that we used to kind of bring in our first set of sentences to annotate. And of course, we want both positive and negative examples. We want the word housing to be used in a situation that doesn't describe their housing situation. And for example, sleeps in or sleeps at or lives on could could refer to something about like sleeping on their side, for example, which actually shows up a lot with people with various medical conditions. It also could be sleeping on the street, right? And those mean very different things. So we wanted to make sure we captured all that space. And at the end of the day, the binary classification that we went with, and I think this is really important, is that does the member have a housing issue that community health partner might be able to address to improve health outcomes, right? This is very actionable. We didn't necessarily want a classification model to do something on an academic definition of housing insecurity or whatever, right? We wanted it to be actionable for ourselves to impact our members' health. And so that was the classification model that we wanted to build. But as we were going through the annotation, we decided that since a human, initially Kate and I, were going to be going through and reading all of these notes, we might as well capture more nuanced information. We know that there are various housing states that people can live in. And so this little switcher code on the side sort of shows us the different levels of housing status that we actually captured, and then how it maps to our binary at the end. So in the end, somebody who was unhoused or housed in a shelter or had inadequate or insecure housing or just had some other sort of catch-all housing issue was true for the case of our model. Like, does this member have a housing issue that we could possibly help with? And anything else went to false. But we figured by capturing this extra information, now we can possibly use this for future use cases later. So for example, you could easily imagine that we might want to do some analysis specifically on people who are living in shelters, right? And so we could build a model from the same label data. And it didn't take us much longer to use 9 classes instead of 2 as we were going through it. The other thing that became very clear to us as we're reading through this is that not only does our housing status can be described in many different ways, but it's actually very ambiguous in a lot of cases. And so here are a few more examples of cases where it's a little unclear what some of these mean. So she goes to a PT 3 days a week. She reports issues with housing. She states she's been wanting to move out of the current house for over 3 years because the house is not accessible. Her bed is in the lounge area, and the bedroom is not within reach. So this is somebody presumably with mobility issues. And this is really interesting, right? She's been living there for 3 years. So presumably it's stable to some point, but it's also probably not ideal for the health outcomes if you're sleeping in a lounge area, which sounds like a public space, right? So, probably this is something that the community health partner at Cityblock can help this member find some housing that's a little more appropriate for their needs. But at the same time, it's stable. It's a little ambiguous. Here's another one. Everything is falling apart in reference to the home he lives in being in disrepair with holes in the roof and many other issues. That one seems pretty clearly that there's a housing issue, but also the person is not homeless, not living on the street, right? It's a little nuanced. Lives in a dangerous area and would like to see if she can move. How much that impacts that member's health depends a lot on how dangerous it is and how stressful that danger is. It's a little unclear. Put in an application for Delta in NE, so she is now on their waiting list to discuss subsidized housing issues, and member would like a bigger apartment that offers income-based rent. And this is another one that's really tricky. One thing I would like to point out is like for Delta in NE, I'm not even sure what that means. That's probably some location-specific information. But the other thing is, maybe lots of people would like a bigger apartment. It's not necessarily clear that would have an impact on their health outcomes, right? So there's a lot of nuance here. It's not as clean cut as just a binary yes or no. Here's one last other one just to point out that a lot of this also changes quickly with time. So a member is in need of services, but weary of cuts to monthly benefits and losing illegal housing. So if you're living in some sort of illegal housing, you might be fine and stable and it might be okay now, but it could be taken away from you at any point. And so, it's really hard to know how this might change with time and how that stress of living in illegal housing might influence your health outcomes. Okay, so just to quickly summarize here, it can be really ambiguous and fleeting, right? So there's some difficulties in labeling data. So for our classifier approach, we basically adopted the John Snow Labs template here that uses TensorFlow graphs to build out a deep learning model. We're not going to go too much into this. We're sort of in early phases of our active learning on this, but for now, this actually worked out pretty well in our initial work with an AUC of 0.81. This was specifically where we're using a holdout set that's really related to just housing related sentences. When we generalize this to like all possible sentences and all the notes, most of which will not be about housing, we expect accuracy to be much higher on that overall set. I also want to point out here that, an AUC and looking at this curve is actually probably a really nice way to think about this, because I said before that Cityblock's overall philosophy is kind of around this preventative work and trying to work upfront to help members' health. And so in the case here, like we'd much rather have high sensitivity at the cost of having higher number of false positives, right? So if we incorrectly flag some people as having a housing issue that do not, that's relatively straightforward to deal with that problem. But it's would be bad health outcome and more expensive for everybody if we missed a housing issue that we then did not act upon, right? So we'd much rather have the higher sensitivity here. The other thing I want to point out is that as we're going through this, for many of these cases, if the note was written by a clinician or a community health partner in Cityblock, like they know the member's health status, right? They wrote it down in the note. So for some of these cases, it's not new information to us. But this can be really useful as we apply this model to, say, incoming members, like as we get new members from our insurance partners that we haven't seen yet. Some of these they come with some health notes, and we might be able to identify immediately some of these new members whether or not they're housing unstable. And we also can use this for sort of like studies. So even though some of our individual community health partners and clinicians might know the status of individual members, it's really hard to sort of roll that up to an aggregate level to do some higher level studies. And so the results of this model would be really useful for that. So like I said, we're still a little bit in early days of our doing this, but we have done a random sample of 124 members that we ran both of our NER approach and our classification approach to. Our classification approach identified in 124 members 9 instances of members that have a note indicated housing issues. And this particularly, it's a pretty small sample. None of them actually seem to be formerly homeless or living in a shelter, but several of them had issues with housing that just needed to be addressed. And so, that's 9 instances of something that we did not know about otherwise. And the NER approach actually only found one indication of an SDOH Z code at all, but it was not related to housing issue, right? So this is just kind of a small numbers sample, but sort of indicating that classification model we really think is the right approach for moving forward with this. So next steps. We still have a lot of model improvements to do. We've only been at this. I've only been at Cityblock for a couple of months, so we're really just ramping up here, and we're really excited about all the stuff we're going to be doing. But we have a lot of better pre-processing that we can do. So a lot of these notes, we use the sentence level detector here, but one of the problems with that is a lot of notes are not written in sentences. So some of them are just written as a bunch of phrases that are just sort of tacked together, right? Just a list of stuff with semicolons in between them, sometimes not even semicolons in between them. And we also have a lot of notes that have like a question and answer format. So there'll be like sort of a standard set of questions that are pasted into each note, and then the clinician or whoever sort of goes through and answers them one by one. And so that question and answer format doesn't actually tie in very well for a sentence level model, right? Because if the sentence is just a question, then the actual answer to that sentence is not tied in there during model training. So we want to address that. There's also things like spelling correction and abbreviations that we can fix up to kind of tidy things up. And we also have found that there's lots of notes that have the same text block that has been copied and pasted in there. And this is interesting when it comes to housing, because many of our community health partners will paste a resource about housing into the note. And it might be the description of a particular housing and where it's located, like a shelter, where it's located, its hours of operation, and who it serves. And it has a lot of words about like helping homeless people and various other things, but it's not actually specifically about the member, right? So, we need to address that. We have some work to do with tuning the model. And as we go through our active learning loop, add in additional annotations. One thing that's interesting as we're growing and sort of expanding areas in which we serve, we're going to be bringing in new providers. And so one thing we found is that notes can look very different depending on who wrote them in which context. And so we want to make sure that we fully capture the whole parameter space. So our model is pretty general purpose, and you can give it a clinician note from a behavioral health specialist or a primary care physician or a community health partner, and it would be able to work well through there. And now I'll pass it back over to Kate to sort of talk about operations and what we're going to do next there.
Great, thanks. So once the model is working to our expectations, we can actually start taking operational steps based on the outputs. So we can put the model into production, run it over larger data sets just to gather more data. We can build out a framework for intervention. So we can actually start prioritizing members for housing assistance for patients in need. We can figure out how to age notes, which is to kind of establish trends as the patient's note content changes over time. As we saw before, a person can go from an unhoused to a housed status. So this is all important when we're thinking about, when it's written. And finally, we can apply the same framework to address other social determinants of health. So food insecurity, income insecurity, substance use disorder, behavioral health conditions. All of these are currently underreported in claims data and really great candidates for a classification approach. So in summary, SDOH conditions are incredibly important, but often overlooked, and a very serious factor in health outcomes. The data can be complex, ambiguous, and change over time, and often it comes in an unstructured format that can be conveyed in a variety of ways. Identifying housing insecurity is not an NER problem, but rather it's more of a classification problem, and we think that our classification approach really shows a lot of promise. So we're just getting started in building out our NLP capabilities, especially around SDOH, and we're really excited about what's to come. So thanks everyone for listening. Really looking forward to your questions.
What an excellent presentation to end this conference day. A huge thank you to all the speakers for their insightful talks covering state-of-the-art NLP in healthcare and life science. Many thanks to all of you for joining this community event yesterday and today, and for contributing with questions and with your own experience. Over the last 2 days, we have heard more than 30 sessions how NLP is leveraged to improve quality care for patients, the work of medical professionals, as well as how the technology can be applied to accelerate innovation in healthcare and life science. There are so many amazing applications of NLP in this field, and we are excited about everything that is yet to come. If you'd like to catch any of the sessions again or watch those that you have missed today, you can come back here and watch all the content on demand for the next 2 weeks. All the content will be available on this platform shortly and will remain public afterwards. For all of those who would like to dive deeper into applied NLP, we'll also be back next week with 4 days of virtual Spark NLP training and certification. The workshop will walk you through state-of-the-art NLP using Johnson Labs' open source Spark NLP library, as well as the Spark NLP for Healthcare library. Check out the link in the chat to see details and to register. Once again, many thanks to all of you for joining. We are very proud to be part of this amazing global NLP community. Keep in touch and have a wonderful rest of your day.